All right, welcome. My name is Dr. Dar Radfar. I have a very special guest with me, Dr. Timothy Kodack from HDX Will. He's the CEO. He helped train me in CBCT technology, especially when it comes to sleep apnea. I'm going to have him talk for the duration of this webinar. I am coming to you live from Toronto. As I said earlier, I saw Niagara Falls earlier today with my son. Well, what a beautiful thing to be able to come to another country, Canada, and be able to present to you all something that's been a big pivotal thing for me to use in my practice when I'm able to screen for sleep apnea. And some of you who've already come to some of my webinars, the passion that I have for sleep is deep. If you don't remember or you don't know, I fell asleep at the wheel in 2009. I crashed my car into a tree, not knowing that I had sleep apnea. And if someone did a CBCT on me or someone did some sort of evaluation of my airway, maybe I wouldn't have had by accident, right? And so our goal here as practitioners is to be able to learn as much as we can in the screening tools that we have so that we can educate our patients. The biggest thing I've been asked by a lot of my coaching clients for sleep is, how many of these patients are coming in through the office that have sleep apnea? And I kind of want to go over these numbers with you all because the numbers used to be 30% of patients walking through the door would have obstructive sleep apnea. Now that number has crawled up to 34% in new studies across the country. If you go to Kentucky, it's close to 44%, which is one of the higher end states in the country. So if you're having 20 patients walk in through the door, around 6 have sleep apnea. And we have to remember these 6 patients who have sleep apnea, if they're left untreated out of the 20 that are walking in, that's 12 to 15 years off their life. When I was at the CDA, California Dental Association, a couple months ago, I started off my presentation by asking people just to Google sleep apnea and life expectancy. And there was a little bit of a silence. People were, kind of shocked to see what AI gave them as the answer and some of the websites and the studies that it showed. And you're really looking at roughly around 10 to 15 years is what some studies have shown for sleep apnea that's left untreated. And nothing really in dentistry that we do adds 12 to 15 years to someone's life, right? I mean, of course, we know perio is important and it leads to heart issues and memory issues and Alzheimer's, dementia, autoimmune issues. There's a lot of things that in dentistry that improve the quality of the life of the individual. But really, sleep apnea is just as a reminder, it's a lifesaver. It's a relationship saver too. I did a webinar on sleep divorce where a third of all marriages or partnerships that live under the same roof or sleep under the same roof, and the people snore, they sleep in different bedrooms, right? So there's a powerful impact here, and there's a lot of ways we can start looking at the patient when they walk in. And the way we can look at them is we can look at their medical history, and we can definitely figure out what kind of background medically they have when they walk in through the door that could indicate to us that they don't sleep well. A lot of times when we do not get enough good sleep, it affects our heart, it affects our immune system, it affects the memory. It does a lot of issues or things that affect your mood, for example. Anxiety and depression have been linked to sleep apnea now, so mental health issues. And so, when a patient walks in, when I see these kinds of signs and symptoms that we've gone over in previous webinars of large scalloped tongue, lower anterior wear, I look at those as red flags, but I also ask them, how often do they get sick? Do they have short-term memory loss issues? Sometimes they tell you, I'm starting to forget things. Memory loss is a big thing. And really, at the end of the day, low energy, being more tired throughout the day, or daytime sleepiness is one of the biggest red flags for sleep apnea. And in the medical history, when I look at the patient's chart, and you guys can do this tomorrow or whenever you go in the office next time, and you see, again, red flags. What are those red flags? High blood pressure, stroke, a history of stroke, congestive heart failure, any heart issues, including arrhythmias, or any sort of heart attack in the past, right away, I ask the patient, how well do you sleep at night? Does anyone tell you that you snore? Do you feel tired throughout the day? And that can lead to using diagnostic tools such as a cone beam to be able to evaluate the airway, which Dr. Kodack will go over in a few minutes for us. Some of the other comorbidities that we talked about is, yeah, sure, a lot of obese people do have sleep apnea, but don't always judge a book by its cover. I'm actually, at weight, and in 2009 I was underweight, and I still have a jaw relationship where my mandible was a little bit more retruded. My palate is high arched, so my soft palate's a little more forward, and my tongue is a little further back, and caused me to have sleep apnea and have my accident. So don't just look at someone being overweight, but that is one of the comorbidities or the red flags that I look at when we are screening a patient. And one of the biggest ones that has come out from the University of Wisconsin is cancer. 5 times higher risk of cancer of any kind if sleep apnea is left untreated. So when a patient comes in and they have history of cancer, or they're wearing a beanie and they've lost their hair and they're going through cancer treatment, it's really important for us to have that conversation. How well do you sleep at night? Do you feel tired throughout the day? Has anyone told you that you snore? And guide them down to a home sleep study, which I've gone over many webinars in the past. And today I want to really talk more about the way we kind of look at the patient as they come in, and how we can have this conversation with them by first looking at their medical history, and then at our own office having tools like the CBCT to be able to evaluate their airway with and without an appliance. One of the biggest ones that I've seen is frequent nighttime urination. The urologist in my neighborhood, that's called nocturia, by the way, refers anywhere from 2 to 5 patients a month now. And it's been becoming more prevalent that nocturia is a reason to get a home sleep study, and ultimately to be able to get treated either with an oral appliance or a CPAP. Of course, diabetes type 2 has been also a big comorbidity associated with sleep apnea, affecting insulin growth factor. And then GERD, acid reflux. And we see a ton of patients in our office with acid erosion, class 5 lesions with the abrasions that have happened. That's also associated somewhat with acid erosion if the dentin is exposed. And so GERD is a big comorbidity as well. So you've got heart issues, you've got stroke, you've got overweight, you've got mental health issues, cancer, diabetes, acid reflux. I mean, we see these daily in our patients when it comes to their medical history. And then when you look at it, you wonder what the percentages are that patients who have these comorbidities or conditions, it comes from sleep disordered breathing issues. And about a third of high blood pressure patients, the sleep apnea is affecting their blood pressure. So I've had plenty of patients documented that we've got them off high blood pressure medication a few months after their diagnosis and wearing their oral appliance, let alone if they wear a CPAP. So there's a lot of medical comorbidities that we can improve, as you can see here, that are correlated to sleep apnea. The last year or two, ever since COVID kind of happened, mental health has become a big topic of conversation. And when I see a patient walk in and they have a medical history on their Prozac or any sort of antidepressant, you kind of like, you have to take note of that, right? And a lot of it has to do with not getting enough good sleep or getting enough oxygen while you're sleeping, because it depletes serotonin levels when we don't get in the REM and in the deep sleep state during our sleep patterns. And so if we're not getting enough REM, we're not getting enough serotonin production, we tend to wake up more tired and more grumpy. I mean, when was the last time you all slept poorly and had that positive mindset when you went to work or around your loved ones? So there's a lot of, it kind of feeds itself. Depression and anxiety makes you sleep poorly, and sleeping poorly makes you more depressed and have more of a fight or flight response because of the cortisol release and the stress that your body goes through when it's not getting enough oxygen, therefore causing more anxiety. I have this video that I want to show you all because some of you have asked me, how's this mouthpiece work? We watched this video for about a minute and 40 seconds, and it shows kind of an animation of what happens when you put the oral appliance in. And this is kind of important because it leads to, right after this, when Dr. Kodack goes over how CBCT can be used for airway evaluation. So let's go and watch this video here.
Sleep is a basic necessity of life, but even more important is breathing. When you sleep, air travels through your nose and mouth, down the throat, and into your lungs. The narrowest part of the airway is at the junction where the soft palate, the tongue, and the back of the throat all compete for the same space. When you are awake, the muscles are tight, keeping the airway open. But when you sleep, these same muscles relax, causing the airway to narrow. As the air passes through the narrowed opening, the uvula and the surrounding tissues begin to vibrate, causing a condition known as snoring. If the tongue continues to fall back, it will cause the breathing to become slowed or completely stopped. This is known as obstructive sleep apnea. Sleep apnea can cause fragmented sleep, shorter lifespan, reduced quality of life, and even death. A comfortable and effective option for treating obstructive sleep apnea is with a custom-made, removable sleep appliance that a dentist trained in the treatment of sleep apnea can provide. With the sleep appliance in place, the lower jaw is prevented from falling back, keeping the tongue forward and the airway open. Often this will reduce or eliminate snoring and sleep apnea, providing the body with deep, restful sleep.
So you all just saw an animation about this, and this is how we're going to dive into having Dr. Kodack go over what CBCT is and how we can use that in our practices to be able to see that distinction of the airway, the palate as it goes down the trachea, and the difference in when you have an oral appliance, how that can improve from one image to another. So I'd like to invite Dr. Kodack to jump in here, CEO of HDX Will. He's a great guy, very funny guy. When he came to my office, I think he made me laugh. And he also diagnosed my my vertebra, my C1, C2 looked like it was collapsing on my CBCT, and I have some arthritis. I think we all are going through some fun neck issues in our dental profession, and everyone can relate. After 23 years for myself of being a dentist, it does affect your whole entire body. So let's welcome Dr. Kodack. Go ahead, Doc, if you want to jump in here.
Absolutely, absolutely. Thank you very much. I'm going to go ahead and jump in and share my screen real quick. There we go. And we'll jump into it a little bit. So again, just to get things started here, and let me get it to where we can actually see it there. There we go. Again, my name is Tim Kodack, and I'm the CEO of HDX Will North America. And I'm here to kind of talk about CBCT radiology and diagnosis, treatment planning, and acceptance of airway treatment, because really that's what it comes down to is that just like Dr. Radfar had said, that, some of us have different portions of the diagnosis associated with sleep apnea and sleep awareness. And part of our conversation is not only that some of these people already know they snore, they have problems, but it's being able to show them what's going on and help them to be able to get to that treatment plan. And CBCT can not only help to diagnose, but also help to be able to create that conversation and get that visualization to them. So we're going to kind of explore the value and insight of CBCT analysis and see where we go from there. So now, as we do so, move through here. Let's see if we get mine. Okay, so again, my name is Tim Kodack, and I'm the CEO of HDX Will North America. My life before this is I was actually the Director of Education for Johnson & Johnson, Pew Synthes in orthopedic trauma and craniomaxillofacial trauma. Craniomaxillofacial trauma is what brought me to the world of dentistry and CBCT, but it was also the understanding the anatomy and being able to translate those two pieces together to do that. And then, of course, I also, he calls me Doc, but again, I was a PA in my other life, and I was a clinician for 12 years. And so, again, I did orthopedic trauma surgery with my hands and actually had cancer. I lost my left scapula to cancer. So I get to live both worlds and understand a little bit more about treatment planning, but I also see it from the medical device perspective of what we can use to be able to do this as well. So it makes an interesting perspective to be able to put this all together. Now, as we go through that, again, our agenda for what we're going to do here today is we're going to understand about CBCT imaging and what it can and cannot do. We're going to look at primarily a preliminary image assessment, tools for the airway and visualization so we can see the things that are out there now, the advancements that have happened for what we can see with CBCT. We'll look at some case studies, and then we'll do some question and answer along the way. Now, again, I'm going to briefly go through the CBCT technology because, again, it's important to understand radiography as well as MRI, as well as all the other adjuncts we can use to be able to visualize some of these things. So again, what I love to do is that even if you have a CBCT, I find a lot of people don't understand what the heck the technology is. So quickly defining the technology that I'd like to be able to show something like a regular CT scan. When we talk about a CT scan, again, because of my cancer, I get one of these every year for the rest of my life because they want to study me. I'm the longest living survivor of chondrosarcoma in North America. As a weird little sideline to everything else, I think we all have inspirations that bring us to where we are. But as we do so, when you go to a medical CAT scan, you're going to lay down on a motorized table and you're going to go inside the big donut. That donut's going to go around you and make little slices along the way. And those slices are going to be stacked together in the computer so that you can create coronal, axial, and sagittal planes. But it's still an X-ray device. So X-ray device, the easiest definition is a densiometry, right? That X-rays basically go from black to white, depending on the density of the object that's going in the beam itself. And so when we look at things like medical CAT scans, not only do they have a higher range of KVs and MAs, but they also have it to where their diagnosis is a little bit more into soft tissue than even the CBCT is, simply because of the fact that you're using a higher gradient. So in trauma, we would use it for things like where we are CTing a head on a trauma patient to be able to define blood from brain and where that blood was going and if it was affecting the brain as well. So it has a little bit more usage in defining soft tissues. Now, if you want to really define soft tissues in the human body, then we start looking at things like, certainly we can use ultrasound to be able to see that. We can see movement and motion when we do ultrasound. But really, if you're defining different layers, then you're looking at things like an MRI. And then what an MRI measures, in the simplest terms, is it's measuring water. It's measuring a polar molecule in each tissue. Each tissue is going to have a different level of that polar molecule. And in that magnetic field, the sensor will be able to pick that up. So we can define muscle from tendon, from bone, from ligament, from meniscus, and so on and so forth. So just a brief overview of things that are going to, if you whatever you're looking for, find the right adjunct to do so. But again, even in medical CT, it's comprised of 2D images of the coronal, axial, and sagittal views. Now, when we get into CBCT, that CBCT becomes different because instead of taking slices, we take full face views from 360 degrees, and we stack them together. And because of the fact that we're not looking specifically for soft tissue differentiation, but more of just spaces, that we can be able to look at it. We use a lower dose radiation because it's pulsed radiation as opposed to a constant beam, but that we get a volumetric image. And that becomes really important as we start talking about airway and making those assessments, because now we can actually see the airway. We can see the mechanics of what's going on and what all those other pieces and parts we've had before kind of come together to make. But again, the resolution, because we don't have to make slices anymore, we get much finer detail associated with that. So now as we go into diagnosis and treatment planning, that, again, as I said before, you have X-rays, CT scans, MRI, cone beam CAT scans, and ultrasound to provide those detailed images. Cone beam can give that clinician the diagnostic advantage in your office of the assessment and treatment of that patient. And again, that communication component that really becomes important for them to accept that treatment plan. I've always had the adjunct that when we talk about in a clinician's office, we have 3 jobs. We have to diagnose, we have to create a treatment plan. But if we can't get the patient to understand that treatment plan or accept it, then that treatment plan is no good. And so we need to find better communication tools to get that across. And because we can do that, we can also help be able to diagnose those structures of the sinuses, nasopharynx, oropharynx, and pharynx area so that we can be able to give them an idea and give ourselves an idea as what really needs to be done to improve this airway. So now, when I go into this, what I'd like to do is I'm going to go ahead and keep sharing my screen, but I'm going to actually go through and we're going to actually work this as though we are working the software itself. So let me get into here a little bit, see if I can get my computer to allow me to do so. I always love to do this. All right. And we're going to look at some CBCT images and really look at assessments of what's going on. So I'm sorry you have to look at my horrible desktop for a second, but that seems to be going away really quickly here. Now, as we do so, and we look inside, that as we start to look at CBCT images, as I said before, what we're really looking at is hard tissues. But in the process of looking at hard tissues, we can also be able to see soft tissue outlines and what's going on with that. So the CBCT in your office becomes that tool to be able to take a look at it. So now as we look over here and we look at the CBCT image, we can normally see it again. You have to get a CBCT image that you're able to see what you need to see. And we're going to talk about this in a couple different case studies. But the idea is being able to see the nasopharynx, the oropharynx, and the pharynx down in here, and even in the sinuses, because as I lovingly like to tell people that if we're only treating everything from the hard palate down, we can make a wonderful mouth breather if we understand what the nasopharynx and the sinuses are doing ahead of time and how that airway pathway from the outside world to that airway gets there. And so again, in this patient, we can see a fairly distinct airway. We can see it from the nasopharynx down and be able to make that assessment. And again, now when I talk about tools to be able to make that assessment, certainly we would love to be able to visualize this and say what's going on with it. But now we have the ability to be able to go through and we can map out points inside that airway. And as we do so, that now we have the opportunity to be able to look down that airway itself. So because X-rays can see air, soft tissue, I'm going to change this to soft tissue because that's what the airway is made out of. And now as I go through and I click on airway, then now I can walk through and I'm in the nasopharynx. And I can be able to drive into here so I can see things like there's a tonsil here and there's a tonsil here. I can even look back at the nasopharynx to kind of see what's going on in the sinuses and where it starts separating from the sinuses into the nasopharynx. As we keep going around, there's the back of the throat. Move around the corner. And now as I look down, there's my soft palate. And I can keep scrolling through and I see my soft palate and I see the back of the tongue and I see where that stricture of the back of the tongue actually happens against the back of here. And of course, what's behind this back of the throat here is the cervical spine. And so we have a finite point in which this soft tissue has a space to be in. If we keep moving through, we can go through. Now we're into the pharynx. There's our epiglottis, over the epiglottis and into the trachea itself. But even in the sense that now we can be able to visualize inside of there because we can choose the type of densities that we're looking at. So instead of saying that I can visualize soft tissue in this case, what I'm looking at is the density change, or the space in between, to be able to make that analysis. Now, again, in this patient, we'll talk about doing airway assessments. I think one of the most important things to remember in making an airway assessment is the old golf adage, play it where it lies. In other words, what we don't want to do is we don't want to manipulate the manual in a certain position to be able to make it to where it may falsely give us an idea that the airway is open. So a perfect example is this patient here again, because we can see that they were on the bite stick in the bite groove. And so in this case, we can get a false impression that this is a fantastic airway because we don't really know what they're actually doing. They may be forcing their mandible into a position that's actually opening up that airway further. And in fact, in this case, that we can actually see that, and I'll move this across and do that little endoscopy feature again, coming from the lateral side here, that in this particular patient, I'll turn this back into bone, that we can see that because they're biting on the bite stick in the bite groove, look at how it's advanced that TMJ condyle out of the joint. So we actually have an advancement of close to, we can measure this out and see that because they've been on the bite stick, that we're looking at this larger space that we're able to take a look at. And as we do so, that now if we were to take them out of that bite stick, what would their actual airway look like? So it's very important that we're making these visual assessments to be able to make sure that patient is in the bite stick, not in the bite stick, but actually in occlusion, so that we can be able to have where they lie, where the jaw actually sits, to know exactly what's truly going on with this patient. So now when we go into other ways in which we can look at this, that now we can go in and we can start to do volumetrics of the airway. Now, doing volumetrics of the airway usually meant that you had to segment out the airway in some way, shape, or form, and then be able to create a volume from there. with advancements in imaging software and the rest of that, then now you can be able to have it detect at those points for you. So again, in this case here, we have that same patient. Looks like a lovely airway here. We can go through and we can ask it to detect the airway for him. And it's going to try to detect it from the nasopharynx all the way through to the pharynx as we looked through before. Now, as we do so, we get a volumetric assessment. We can look at it, we can turn this patient to the side, and now what we get to see is we get to see the structure. So here's that nasopharynx where it moves from the septum into the nasopharynx. We can change it for colorization so we can see those cross-sectional areas, so we can see where it's the tightest. And again, here's that back of the tongue here, so we can see what's going on. Even better is now when I do that at endoscope, I can look down, and as I fly through that airway, I can see where those tight spots are and be able to say that, okay, well, obviously at the back of the tongue is where the stricture becomes the tightest in this particular case. Now, as we go back over here, that we can also go through and we can look at it, we can be able to assess it, but that volumetrics is really important because now it becomes something where we can be able to start putting numbers to what we're doing. So if we do that, perhaps that mouthpiece that we were doing before, advancing this patient's jaw forward as the bite stick is doing in this case, then we can do a before and after and get a volumetric assessment of what that is. Now, it's important to realize that this volumetric assessment isn't something that is standard throughout everyone, because obviously we all have different anatomies. And so a smaller person may have a smaller volume of that assessment. So it's relative to the patient itself. But again, it gives you that tool to not only look down the airway, see what's physically going on, but that you can measure it between pre and post treatment to make the decision to say that this has actually physically opened the airway and made it something better. All right, so now one of the ones that I love to be able to show is we're going to torture my wife for a little bit. And we did my wife's CBCT. And she was so much of a willing victim. I always think it's lovely to be able to experiment on your wife, but we have a CBCT of her. And just to kind of go through that, again, adding that sort of either facial scan or facial picture gives us really a story of what's going on. So in this case, we can give her the full face and see there's Anna. And all we did was just, in this case, superimpose a 2D picture over top. But now what we have is we have a clinical study that we can look at. We can see the little facial asymmetries as we go along, but we can see, at least in this case, her bite looks closed. We can look at it from the side and be able to see the same thing. She's not sticking at her tongue. That's the bite stick that we did. Now, in doing so, again, I wasn't really trying to assess her for airway at the time, but as we get into her images, we can see that, number one, just like my wife, that she didn't follow instructions. So she didn't bite on the bite stick in the bite groove. And this was actually fortunate in this case because now we really get to see the difference. And you can see the difference in how much she would have moved her mandible to get into that bite groove to be able to open up that airway. Instead, we really get to see her airway from a true perspective of look at how small it is here. And so we can be able to say, and again, I know this for a fact because I live with her. And just as you said, relationship issues that unfortunately we both snore. But she does snore. She's a very petite young lady. So it's not about obesity. It's not always about that, but assessing the total patient to see what's going on. But she is hypertensive as well. So she has a number of those comorbidities associated with that. But as you look at that, you can see how foreshortened her airway is as she's, and again, this is an upright position when she's conscious. Can you imagine what happens when she lays on her back and sleeps at night and those muscles relax and all this comes laying back against the spine and really closing off that airway? Now, really the thing I like to be able to teach when I go and do this is we talk about doing image assessment and going through there and again, making the full story. So if I'm going through Anna, I'm looking at her full skull here, and I like to go from right to left or left to right in this case to be able to kind of see what's going on. So what I'm looking for is I'm looking to see our TMJs are in place. We're moving along. I'm looking for any sort of bony anomalies as I move across the way. Again, I know she's in a bite stick, so we have a little gap here, but otherwise, as I come across here, I really don't see anything that jumps out at me right away as any sort of anatomical issues. As I go along, yes, she has some dental issues, and as dentists, you guys will attack all that just fine. And now we've gone left to right looking for anything really outside the dentition to make sure that we know what's going on in that image. Now, to assess a human skull, probably the best image to be able to look at is looking at the coronal view. Because as we look at the coronal view, everything should be equal on right and left. We are a biplanar animal in the skull area. So as we move through, this is a great way to assess an image and kind of be able to see what's going on in the anatomy and make sure there aren't any other anomalies going on. So we're going to go nose to tail in this case. So there's Anna's nose, and we go across. And as we go across, probably one of the important things to see right away is that, oh, well, by the way, she does have a little deviated septum here, at least when we can see the beginning of a deviated septum. But look what we can see as well. We can see this kind of sinusitis that's going on bilaterally. And so we know that she may have either sinus issues or that she was having a sinusitis at the time of the exam that we can look at. And again, all these things can be factors in the assessment of her airway. But now as we keep moving along, look at how that deviated septum changes. And so now, honestly, she really is only breathing through one nostril as she moves about in life to be able to do that. So her left nostril is wide open, her right nostril is kind of fairly occluded in that sense. Now, as we look at that and we put that picture with this picture, that as we look at that, that's why I like to be able to say that only looking at either from the hard palate down or even in the nasopharynx alone, that you don't get the whole picture because we do all the treatment planning we want to. We open up this airway, we're going to create a fantastic mouth breather. But if we don't realize that we need to be able to look at this assessment and be able to let them know that the treatment plan isn't going to be in full effect until we're able to find at least a way to correct this in some way so that we can open up these air passages, then we really have only done part of the job associated with looking at airway, assessing it, and giving her the optimal chance to be able to have a positive outcome from that airway treatment as well. So now, again, going over to her, that we can go through, and we'll go over to the airway module. I'll have to load up one of our other ones here. I've played with her too often here. That as we look at our airway module, that now we're going to go through and get that volumetric analysis of what we have. And so this is kind of the pre-planning. This is also the way in which we can be able to talk to our patients and be able to say, Anna, so we have your scans. We can take a look at them. We can show that, first of all, I'm seeing a fairly deviated septum. And that's something that we need to talk about referring to an ENT or someone that could be able to fix that deviated septum. But as we move through, we can also be able to see that as I go through and do her assessment here, that now we can get a volumetric for Anna's airway. And now as we look at Anna's airway, it's almost terrifyingly small. And in fact, I'll go ahead and I'll take away the 3D view here and just do the airway surface. And now look what we can see. So nasopharynx in the back is wide open. You still see there's a little bit of differentiation there. But that's a deviated septum. It's kind of changed in the back here. But now as we go along, look what we're seeing is right at the back of the tongue. Look at how horrific that is. And if you colorize that to cross-sectional area, look at the length of area that she's having, that she really has a very small area for that air to make it through. And again, looking at the endoscopy as we move through, we can see as we move through that look how tight that gets. And again, this is her awake and upright to be able to do this. And so you can imagine that along with hypertension, that these are all comorbidities to other things going on, heart disease, and the rest of this we've found out. And so, but when we get this patient in our office, this is the way we can communicate, because being able just to describe it, again, when I was a clinician, all I had was a white coat and a good story, right? And so I had to be able to be not only entertaining, but I had to be able to try to describe not only what their ailment was, but the treatment plan associated with that ailment and the outcome of that. Well, now we have a tool that essentially paints those 1,000 words for us, that we can go through and we can show this is how tight it gets. And if we're looking from the outside, that this is what your airway looks like. And this is why you're struggling to breathe at night. This is why you snore. And this may be other reasons why you have, sleeplessness and adding to the hypertension you already have, whatever, that now you're looking at even higher comorbidities for heart disease and heart attack and the rest of that. So this really gives us that tool to walk through and be able to give them the idea of what it looks like and how we can make that assessment along the way. So now I'd like to bring in Jade. So I was doing a lecture out at the University of Oklahoma, and there's a number of different reasons why we have airway changes and the rest of that. Well, Jade was a graduate dental student who was smart enough or nice enough to be able to get a CBCT done for the class. And so we were going to do a lecture on CBCT evaluation. So here's Jade. And she's a 27-year-old female of relatively good health. And of course, again, this picture helps us to be able to have that conversation. It also helps us in this case to really go back to the case study. So again, as we look at Jade, again, we see a little bit of facial asymmetry as well. We also see what may be a little exophthalmia. So she may have some thyroid issues associated with that. But we can see that she's got some fairly large eyes. We can also see as we go down her nose and, oh, right in her mouth, we can see what looks like an open bite. And then on the sides, we can see that she's kind of got these little chipmunk cheeks, but especially way at the back of the mandible as well. And so in just being a clinician, you go through and you say, so do you have anything like TMJ pain or anything else like that? And her answer was, well, certainly, I'm a dental student, lots of stress, getting ready to get in my own practice. So I do on occasion, but not that big of a deal. Now looking at her from the side, now we start to see things like, well, I said, do you snore? And she goes, well, yeah, how do you know? And what we can see here is that upturned nose, that inset chin. And so as we look at that, we can already see the anatomical cues and clues for us is as clinician detectives to be able to look at all these pieces and put them together. And so we can see now that she says, yeah, well, I snore. And she said she had TMJ pain as well. So these are all clues in which we need to be able to look at and assess. So now we go through and I do the same thing I do every single time, which is I'm going to go ahead and take her image and I'm going to do my assessment of just around there. And of course, what she tells us as the image pops up is, oh, by the way, she had a Lefort procedure done as a child. And so I thought, well, fantastic. We get to see all sorts of fun things to teach the class with. So now as we go through, here's Jade. And as we look at Jade, we can see again from left to right as we go across. And again, because she has that Lefort procedure, I really want to look at not only all the other bone, but I also want to look at the maxilla because that had to heal back along the way. Now, she had this when she was 13 years old. Now, as we move across, Lefort procedures, by the way, can be done for a number of different issues, but one of which is to try to create, to move the maxilla to help create that sort of occlusion with the mandible as well. Usually what they would do is they would osteotome off the maxilla, be able to bring it into occlusion, wire those teeth shut, and then replate it along the way. So now as we're moving across here, we're moving around, I'm just going to keep going around the side, and again, just looking for any sort of changes. I can see her vomer bone in the middle. Looks like she doesn't have very much, if any, of a deviated septum. And then we move over to this side. Now, we got over this side. We look at this, and again, even before we get to airway, I see that, wow, I'm seeing a lot of bare teeth here. And in fact, just to give you an example of what I mean by that is I can remove one side of her face, and now we can see that she really doesn't have any bone at all in there. If we look at the axial views, we can see that, in fact, her buccal and lingual walls on that side are almost non-existent. It's just almost just faded away. And so here's our first detective story, right? We've got to figure out what this is even before we start talking about all the things we saw when we saw her. So we look at this, and just to give you an idea of how bad this is, that again, I'm going to go ahead and you can see the spaces in between, but then I want to be able to figure out what's going on. So I'm going through different bone windows or ways in which we can look at the x-ray. And somewhere along the way, I found this. And what is that? That's called a ligaclip. So somewhere in our procedure to be able to do her Lefort procedure, an artery was hit and they had to clamp that off. So now we have an idea that maybe is this a avascular process going on, and it's making it to where that the vascularity from this side of the maxilla is really only coming from the central bone, and really the vascular supply coming from this side has actually been cut off. All right, so story number one, I'm already ruining her day in front of all her classmates. And let's go ahead and put the rest of her face back on. But again, what did we say about that? Things that we can do with that is that we're looking for occlusion. And we can see that she has a very prominent overjet as to what's going on. Now, what were our clues, right? Our clues were, well, as she said she had some TMJ pain. So let's look at that first. And in fact, we'll go in and blow up the TMJs. We can see, wow, they are really, really deteriorated. And in fact, we look bilaterally, you've got less deterioration, but certainly deterioration even on the other side as well. And to give you an idea of what I mean by that deterioration, the best way to describe this is to go over and we're going to do that scope and look at that TMJ. And so what I like to do is not only look at it from the side as we're used to looking at it, but now because of the fact that we have these tools, is that I can take my CBCT, come up to the condyles themselves, and I can take that same endoscopy tool and map out points all the way through that condyle from inside her face. We can look at the actual condyle itself from a different perspective. And when we do, this is what I mean by just crushed condyle. So this is the really affected side. And as we go down in here and we can fly up to it, now we get to see that TMJ condyle. That is advanced TMJ collapse, right? And so we can see here, we can see this osteophyte formation. We can see how that's completely flattened out and given up. We can see this shelf formation here. And so again, this is also a great description of why, just listening to the patient's complaints as to why we assess the TMJ in these situations, because she really didn't have any major complaints for TMJ pain. Yet look at the destruction of that TMJ. Yet we also see patients with horrible TMJ pain, and we'll take a CBCT and not necessarily see a huge change in the condyle, any sort of forming of osteophytes or anything else like that. All right, so now we see that she's got some TMJ pathology. Well, let's see what that TMJ pathology has done for the rest of her image. So I'm going to reset this back. And as we do so, now we look at it from the side. And let's take a look at this. And as we look at Jade from here, we can see that because that mandible is now foreshortened, it's made her airway much smaller. Because remember, this is a finite space. Your spine isn't going anywhere. And so now all these soft tissues have to exist within this space. And again, she's upright, awake, alert, and those muscles are taut, much less when she lays down and sleeps, and all this rests back against this finite space. Now, the other thing we see in this image is, as we look at this, is let's look at the hard palate. Now, the hard palate should be coming out around in this direction here. Should be much flatter in this position. But instead, the hard palate, because it healed in a position that was tilted, that if we want to go ahead and measure that tilt that she's got, that she went from to boom. And that's a 17-degree tilt that happened post-surgically. And now what is that doing for us? That's making the nasopharynx a little bit larger, but it's also making it to where we have this overjet and this open bite that we're dealing with as well. And so looking at those things, this is going to affect the way her airway works. So we go over back to that volumetric analysis. As we go into the volumetric analysis, now here's Jade. And because her anatomy has changed so much with the fact that her hard palate has changed and her nasopharynx has changed, that when I ask it to detect it, it actually doesn't know where to stop. And so what it does is it starts finding things like it starts bleeding into the ethmoid sinuses. And so as we see here, now it's kind of filled up the ethmoid sinuses and doing that volumetrics. Well, that doesn't really help us as far as that diagnosis. So I would go back and I would remove that. And look at it again, and from a manual perspective, and say that I'm going to find the best perspective of that nasopharynx to pharynx and be able to just create points to make it to where it'll stop where I ask it to stop. So nasopharynx all the way down to pharynx. And now we'll mesh out that and really get a volume that could be comparative to what we're going to do. And so again, in this case, now we can see her volume doesn't look all that bad. And in fact, if we isolate this out and we look at only the surface of there, then what we can see is that she has fairly large pathways to the side of the tip of the tongue, but right at the tip of the tongue itself, it gets tight. So as we look at the endoscopy, but now again, this is all part of that process of understanding what the physiology that's going on in there is to know how can we affect a change and what needs to be done to affect this change, and look at all these to be able to see. So although the red really was indicated for where it came out of the nasopharynx, this is where we can see that this is really the tightest spot that we're seeing here in this particular patient. All right, so now we talked about positioning the patient and making sure the patient is not on the bite stick and those type of things to make sure that we're getting a appropriate assessment. Again, you can see here she was in a chin rest, so she was in a chin cup. So this is her occlusion and the way that we did that. So now other ways in which we get CBCTs is we want to be able to come up with an actual action plan for how we're going to take that. Because if we just put them in there, we're not really getting the full story. Because the patient swallowed, if they're breathing during the time, that airway is moving from spot to spot. And so the CBCT is going to have a harder time defining out these edges, right? So coming up with a plan, such as if you're going to be doing airway assessment, yes, in a edentulous chin cup so that we get them in occlusion as best we can. And then I usually would have the patient gargle first, get any sort of mucus out of their throat or anything else like that. And then from there, be able to say that you could go through and you get them in the chin rest. And then you ask them to take in a deep breath. You ask them to exhale and then hold their breath. When they hold their breath, now you're not going to get the movement of the airway along the way, but you're also going to be able to see it. Now, if you tell them to hold their breath and keep the air in, you're going to artificially inflate this area. Whereas instead, that if we tell them to take a deep breath and then exhale, we really get an idea as to where that airway is and how we're able to assess the true volume that's left after they get through inspiration and expiration, or when it's at rest. So we really get it at its worst point, and we can be able to then assess that. And then again, at the end, we do our follow-up. We're going to do that same modality to make sure we get comparative images. All right, so now as we come back over here, I'll kind of jump back into this a little bit. And now, in conclusion, again, it can be an essential role in airway diagnosis. It can provide a tool that gives you the ability to be able to look at the essential airway and look at the pathology associated with that, find other reasons why this airway looks the way it does. And again, we've seen a mechanical reason. We've also seen things like deviated septum and all these other things that kind of come into play. And what can we do to affect a true final change to help out their airway along the way? It can guide our treatments so that we're doing the right treatment for the right pathology as well, so that we can be able to do that, again, get that acceptance, get them to understand what's going on with them, and then be able to get to that treatment plan. And then as CBC tools get more and more advanced, we can do things like endoscopies, and we can do those volumetric assessments. And all those are just more tools in your armamentarium to be able to make those assessments, make those diagnoses, treatment plans, and a successful treatment plan in the end. So at this point, I'm going to open it up for questions and answers I want everybody to have a chance to be able to ask any questions that they may have about CBCT in the assessment of airway. So I'm going to open up the floor here. Let me get this back over here. I see a number of things in the chat. So I'll just kind of start going down them along the way. So when you take CBCT with the bite stick, are you taking images as if they were in MAD? And again, as I tried to address before, that is a false image of what you're looking at as the airway is concerned. You really have to put them in occlusion. You have to play them as they lie, or else you really are getting a false assessment of either where the mandible sits, where the mandible lies, and where the pathology can begin. Edge to edge most of the time is titrated a bit more protrusive, very high angle mandible. Yeah, and again, really the advantages in case presentation, being able to sit there and say that we can be able to show our patients what it is and create that conversation so that we can get on with the treatment plan that we've worked so hard to learn how to do along the way.
Tim?
Yes, sir.
I know one thing that you showed me when we installed the HDX will in my office was the ability to look at the deviated septum and also the sinuses. And that was huge for me because I've had patients that we treat for sleep or they try to mouth tape, right? And good luck trying to mouth tape if you have a deviated septum or you have turbinate or any sort of obstruction in the nasal cavity, right? And so that has allowed me to actually be very communicative with an ENT. Now I'm not just guessing or trying to, figure out how I can make these people more of a nasal breather, because that's the right way of breathing, right? Mouth breathing is not as good as nasal breathing. What are your thoughts on most dentists don't know how to look at the nasal cavity, right, on a CT? Like, is there videos and training and whatnot that you guys offer? I know you did it with me personally when we installed it, but a lot of people don't know how to look for stuff like that to be able to do proper evaluation of the airway.
So, honestly, this is a topic that isn't really being taught quite a bit. And so that's why I started doing lectures on that. So I do a series of lectures on demystifying CBCT and then going through and let's do game planning and assessment of the images. Now, I'm not a radiologist, so I can only do so much in teaching people how to be able to use the tools that they have to look at those and look at the anatomy and appreciate what the anatomy is and create images that they understand. But and again, I have a course coming up in August 16th in Tarzana, California, which we're going to be doing step 2 of that, and that is not only being able to go through and look at an image, but just as I showed the images that I had before, is create a game plan. So the game plan for me is that I'm going to go from right to left. And again, being a dentist, you're going to focus on the teeth anyway. So I kind of leave that out of the things I look at, and I'm going to look at all the rest of the image, looking for any sort of pathology, any sort of anomalies, any sort of neoplasms in the bone. Then once I get to there, then that coronal view gives me that second step. And I do that with every image that I look at so that I don't miss anything. Now, I realize that especially being out of the scope of practice of most dentists, the sinuses become something to where even if you were to diagnose something and you saw something, then it becomes difficult because in the world of anything that it's kind of out of your scope of practice. And so that's when the idea of getting a backup as far as a radiologist is concerned, to be able to get so you can assess that image, you can see it, you have eyes, you know the anatomy, you've gone through all that as well. But once you see pathology outside your scope of practice, it's always good to get that reinforcement from a radiologist, simply because when you go to an ENT, and again, if you're going to go into airway, my biggest thing is I encourage everybody to have a relationship with a local ENT group or whatever that is, because there are going to be things like that deviated septum that are going to need to be treated. But then also having a radiologist report along with your CBCT, so that when that ENT gets that referral from you, that if it's just a dentist saying this patient has a deviated septum, they'll put them on the schedule. But if you have a CBCT with a radiologist report and you're calling them saying my patient has a deviated septum and we have a radiologist report to that effect, you're going to find that your patient is going to get in that much quicker. You're going to get that much better response for your ENT, because now you've validated that as being able to be seen and read. But I always encourage, and I speak at universities to graduate students all the time about, don't just give it up. In other words, make sure that you take the time to be able to learn how to look at these images and learn how to start looking at those. There aren't really a whole lot of courses out there right now doing that. I'm doing a couple in being able to do that from beginning to advanced. But I think in general that I want to bring more radiologists into this conversation so that there's a certain bit of confidence associated with looking at this and what pathologies they should look for in the meantime. And
Tim, how easy is it to be able to get a radiology report once, for example, my assistant does the CT of the patient?
So again, that's another, there's companies all around the United States that do CBCT reading. Our particular company actually has it built into the software, and we have a radiologist out of the University of Columbia that does our readings. But what I would say is that there's other adjuncts that you can find radiologists for. And so whether it be one of the most prominent ones is a company called Beam Readers, but they also do a number of different things as well. There are actually medical radiology groups that are getting involved in this as well to be able to do those assessments. So there are adjuncts out there. You can even go to your local, medical school, and the radiology students need to read images anyway. And usually you'll find sometimes that's the cheapest avenue, but you still get that read. You still get something to where you have that confidence for your liability, for your practice, and for that patient that has been assessed.
Thank you. Let's see if there's any other questions here. Someone's asking, Dr. Rosenstein's asking, do you know Dr. Dania Tamimi's work? And she's a maxillofacial radiologist by any chance?
I don't recognize the name right off the bat. And he also send to Beam Readers. Yeah. That yes. And again, that's what you find is that I would love to get in contact with it, because I'd love to have more people talk about this. There's plenty of books on how to read it and how to look at it. But again, in the end, for your own liability, your scope of practice still is stuck within the oral cavity. And if you start seeing sinus pathology, it still is one of those things that, good, recognize it. Please learn how to look at this, look at those images, but then also look back and say that I need a radiologist to give you a confirmation on that.
Yeah, I think that's the I tell you that the fear that I had was I get this machine right and I'm using it. I'm not well versed in it, because that's not what we learned in any shape or form, even in dental school. And so to be able to have that connected with your CT machine or send it to beam readers, it's really important. Then you feel more comfortable in the report that you get, and as you said, you're covering your ass, so to speak.
Yeah, absolutely. Absolutely. Because you're liable for anything that's on that film. So it's important to be able to understand that and appreciate that so that we get into a situation where we know that once it's out of our scope of practice, even if we see something, it's good to get that validation. And then there's a whole nother discussion about what does referral actually mean in the process to make sure that there's a positive transfer of patient care to somebody if you do see something on that image.
In the last couple of minutes, I wanted to introduce Gabe Hoffman here. Gabe, if you could unmute yourself, you want to go over a couple of things based on ROI. I think you kind of mentioned that right now in the chat.
Yeah, sure. So, hi everybody. I worked with Dr. Rad on his implementation in his practice. I mentioned it. The advantages. I know there was a mention of different units and field of view. However, when it comes to ROI, with CBCT, the rubber meets the road based on the case acceptance and the treatment that's done, that is accepted as a result, the diagnostic capability, the mitigation of risk, right? Those are really the three areas. But truly, the true return is the treatment that we gain that we wouldn't be able to see without the capability, right? And I know that is where the technology is a true aid, not just on the patient education, the diagnostic capability, but the patient education, and then the ability to case present. So while Tim was presenting the tissue adaptation, the primary advantage there, the extra time spent there, is huge advantage for when you're walking through it with the patient, right? The awareness and the understanding. Taking that a step further, that large image, you have the ability to extract a cephalometric scan without having to take one. So in the cases that are more challenging, you also have the ability to extract a 3D ceph for billing purposes. When you're medical billing, there is the advantage in certain cases to expedite reimbursement there as well. Again, that's not going to apply to every case, but I think it's worth mentioning because that is unique to a model like this as well. So when you're thinking about, true ROI on a CBCT, support and service is really like the ongoing learning journey that I think you mentioned, Dr. Rad. That is really key to peeling back the layers and getting the most out of this. Beyond the courses that you go to or webinars like tonight, the ability to connect when you have a patient ready to take a scan and you have a question, and be able to get somebody either on the phone or to even log in and aid you or your team through both the acquisition as well as the manipulation, whether that's day one or day, 423, you still have that service and support, which is, maybe it's not tangible, but there's definitely an ROI in the service and support that you're not handcuffed to paying for a monthly, but yet you have at your fingertips. Concierge level services is really a huge advantage throughout the ownership journey as well.
And Gabe, in my office, we've gotten pre-approvals for CBCTs and billed medically. We've gotten anywhere, the lowest was 282, the highest was 450 so far. So there is, from medical insurance. So there is an opportunity there. Medical billing companies will bill for a CBCT. Most of them do require pre-auths. In the case of oral appliances, especially if you're doing one with regular bite and one with your sleep herb stand, which this does beautifully, even though they have metal hinges, you don't see any sort of distorted image when I use the HDX well, you're able to have the pre-auth in advance so that you can take those pre and post images. And so we've gotten paid on them. But obviously deductibles for some people have applied, but the highest one that we got paid was for a UPS driver because his deductible was $100 and they covered it 80%. So you were right on that when we spoke a few months ago. There are reimbursements that dentists can get from medical insurance for CBCT that you take, whether it's airway or even whether it's just a diagnostic tool for evaluating bone and jaw and TMJ and all that, which obviously this field of view is worth it in my mind, because if you're going to do airway, it's just another tool to be able to
have the field of view.
Sorry?
You got to have enough field of view for it to work.
Yeah, absolutely.
Absolutely.
Yeah. So, and people need to know that those machines are more expensive than the ones that periodontists and oral surgeons use to look for other pathology and to plan implants.
Yeah, no, that's a really good point. I want to go back to something that Dr. Rad said, though, because not only in the medical billing are you getting roughly $200 more per CBCT, and obviously based on your prescription, your treatment, you're going to take 2 to potentially 3 of those when creating an appliance.
Right.
But you also have the diagnostic codes that some medical insurances will cover that dental does not.
Well, you have to use the diagnostic codes or they won't pay.
Well, correct. But I'm talking about the actual reimbursement, Doctor, on the evaluation and the planning, which we don't have on the dental side. So right. that's additional revenue based on the time when you're planning these cases and potential reimbursement.
Real quick, do you off the top of your mind know the difference between the price of a unit with airway and one without?
Yeah.
For sure. And I'm glad you brought that up because, I know there was the mention of the cost. I will tell you that, HDX Will is really unique in the market because they're not only from a support and the education standpoint that you're not having to pay for every time you turn around, but taking that a step further with the price of entry. Typically units with this large of a field of view and this capability, you're paying, close to 100,000 or more for a unit at this size field of view with the subscription to additional modalities, right? The additional, all the apps, if you will, the pages,
facial scanning, external bite wings and all that kind of stuff is excellent.
Yes. And so again, beyond the endoscopy that we saw here, the 3D extractable Ceph, the ability to have, you mentioned the scatter reduction, precision metal artifact reduction. The way that this unit does it, you don't reduce the accuracy, which when it comes to CBCT, accuracy is where the rubber meets the road, right? When you're planning, diagnosing, and planning. And so HDX Will excels in that area. But for a price point that is dramatically less than the market, because the approach with CBCT is everyone should have one that allows them to not only to optimize patient care, right? And so the price of entry for a unit of this size is dramatically less than the range that we were talking about.
I can tell you that I've been researching a new CBCT unit, and the best unit that I've found that will do what I need is the Plan Mecca new unit, but it lists for 150 grand, and you may be able to buy it for about 120, 110, and so it's a big investment. But it does what you're talking about. It does reduce scatter, and it does reduce radiation. It has different abilities to change the radiation exposure based on what you're doing. But it's a very expensive unit, obviously.
It is. And Dr. Rosenstein, that's a good point. Something I'd like to mention that I'm very familiar with that as when I was I had a group of 6 multi-specialty locations, and we had a Plan Mecca unit. That is the newer addition, but they've had that calm algorithm for a
Right.
number of years.
Right.
I worked with a rep at J. Merida, and he was one of the individuals responsible for developing that technology for Plan Mecca. He and his father, and that is actually peeling off layers to smooth the image.
Mm-hmm.
And so therefore is potentially, when you're applying that algorithm, is reducing, again, I can't speak to the percentages, but it is reducing the accuracy as compared to the way that the precision metal artifact reduction is applied with HDX Will. That is a key, not to mention, you like 125, 130 takes it out of the price range for a number of practices.
Yeah, sure.
Whereas, you can get into this model with all the capabilities, all the modalities, the 3D imaging, on-demand 3D with all the capability, for under $70,000.
Really? Oh, I need to know about that. I was not
Unlimited
familiar with
support
that unit.
service. Yeah.
And again, what I would say to that as well is that let's all also realize that with the current tariffs that are going on, that that's going to be
prices are up for debate.
Prices may change.
Sure, they vary.
And they may change very quickly. I know of a number of manufacturers that are already planning on price increases as the August 1st comes about. So that's where, again, this is one of those weird times in history that, especially for this type of technology, that to get into it is to get into it now, because the price of anything that comes from a foreign market is going to go up dramatically, and there's going to have to be a response as long as those things happen. So
Sure.
it is something to be able to address and attack now.
How do I get in touch with HDX Will?
Well, again, I have this QR code up on the screen. That's for our social media. But again, you can also go to our website, which is www.hdxwillna.com. Then NA is for North America, and be able to do that.
Tim, I'll be in the thank you email. You guys will get some information.
There you go. Perfect.
I was going to say, and likewise, you can, if you guys have questions, you can always reach out to me, as well as Tim, and relative to sleep and application or use cases that, Dr. Rad. So if you want to share mine as well, I'm more than happy to be a resource on really the back end, the case and presentation, the billing, like the aspects, that I am, more than familiar with, and in really the ongoing ROI with the unit, and then the application as well. But again, I can't stress enough the learning journey with CBCT, right? It's not a destination, it's ongoing. Yeah. You're peeling back layers, and Tim and his team are top tier in the market as far as concierge level service. For, again, even years down the road in your ownership, right? Because you're always continuing to learn as you bring on providers, your practice changes, you add services, or even situational learning that comes up with a case, right? And I mentioned in the chat, Dr. Kleber Silva is a radiologist that HDX Will has a relationship with. You can use anybody, but he also has some, he has specific experience in the use of this particular unit as well, and an HDX Will images, so and the software. So in his reads, in his description, you get a little bit. It's plus at a reduced price with Dr. Kleber Silva. So but you can use Beam Readers or anybody else for those reads as well. All
right, I wanted to, and we went a little bit over tonight, so I want to thank Tim and Gabe, and actually Dr. Rosenstein, thanks for chiming in there. Got some great points. I appreciate it.
Before we go, I'd really like to I had no vested interest, but for those people that are really interested in learning about the impact of how to use CBCT with airway, Dr. Tamimi's book is just unbelievable. It's called Specialty Imaging temporomandibular joint and sleep disorder breathing, and it's really a Bible. She goes into incredible detail. And when you buy the book, you get access to the online book at Elsevier, so you can look at images. There's videos in there. It's extremely thorough and very, very interesting. And even Tim, I think you'd learn from this book.
Absolutely.
Thank you.
Again, it's
Yeah,
a learning
thank you.
journey.
That's good information.
Thank you.
Absolutely.
For the CE guys, everyone's going to get an email again along with the information for HDX Will. You'll get the email on instructions for the 1CE. Appreciate everyone for coming on. And
Thanks for having us.
Thank you. Stay rad,
All right,
everyone.
take care, everybody.